My name is Dr. Peter Noël, board certified veterinary radiologist. For those of you that haven't joined us, what we're going to do is we're going to try 8 to 10 cases. I'm going to present the case, give you the history, give you the rads. I'm going to shut up. You're going to look at it, see what you think. Then I'm going to tell you what I think, and then you can ask questions or ask me to point things out. So the point is to get you guys to try to commit to something. It doesn't matter how silly you think your response is, but I'll tell you what I think. A lot of these have known outcomes, some of them don't. So you'll just have to take my word for it. Let's see. Anything else? Turn up your monitor brightness, turn down the lights in your room. Okay, so we've got a dog. We got a female dog, and she's probably six years old. 2, 4, 5, 6. We got 6 rads. Okay, musculoskeletal. It's going to start it out. Okay, so we've got right lateral, left lateral, BD, DP, and a lateral. Okay, so the dog's limping, and he's limping on his left pelvic limb. Okay, so I'm just going to try to toggle through. I'll try to window level for you. Okay, you ready? Tell me, why is this dog limping? And we think that he's limping on his left pelvic limb. Enough time? Time. Okay. Scratch it down on a piece of paper. Put it in the comments. It's up to you. But I'm just going to show you what I think's going on. Right lateral view. So what you can see, first of all, the technique's terrible, right? Terrible. This is really bad. I have no idea. And I don't think they know where the animal is lame. And sometimes that's okay, but it's just not great, right? It's not positioned or centered on one particular joint or long bone. It's overexposed. This is pretty good. But again, this is not bad. This is okay. The problem is you got to make sure that you've got this little nubbin on the 5th metatarsal. You have to make sure you include the carpi and the tarsal and the carpal bones when you take these views. Because if you were just to do this, I can't tell you what digit's 2 and which digit's 5. Okay, so they got enough in, but that's fine. This is not good. He's rotated. I don't know where he hurts. So I'll tell you. So Christine pointed out that she's worried that there's decreased coverage of the left. There's atrophy in the left pelvic limb, and I would agree. The one thing you got to watch out for is the right pelvic limb is a little externally rotated. When you externally rotate, that'll make the right look like it has more soft tissue coverage, and then you'll think that maybe the left is reduced. It'll create that asymmetry. This left patella is luxated, so it's a pretty straight. You could drive a truck down down through that intercondylar fossa, and this patella is right there. Okay, you've also got, he's a little bit rotated. This calcaneus is not centered on the mid aspect of that tarsocrural joint, so it's a little bit rotated, but there's some bowing. There's lateral bowing, the proximal tibia, widening the intercostal space. The left patella is medially positioned. Okay, this is pretty straight, and I don't really see, it's probably the patella is over there, so I don't have a luxating right patella. The hip joints are fine. The sacroiliac joints are fine. Okay, so we got a left luxating patella, and we've got reduced coverage, atrophy on the left. But this one I thought was interesting. So they put this spoon and they flex the tarsus, and I think that that's driven this thing into cranial drawer. So these femoral condyles are, if you drop a lead line from here, they're caudal to the tibial plateau, the intercondylar eminences, and so that sort of supports cranial drawer, normal popliteal lymph node. I will look back here on the poof, on the plantar aspect of the tarsocrural joint. I look for evidence of tarsocrural swelling. You'll see it right there. I feel like sometimes it's hard to see it there, so I look there. I don't see it. Okay, this cranial drawer, I like that they took the right, because this one looks like it's kind of getting a little cranial drawer too. So you gotta, I love the fact that they've got this contralateral limb, but when you really kind of look, you go, okay, well, this one at least is kind of still hitting the caudal aspect of that tibial plateau, and this one's missed it. Okay. So I think what's happening is that the patient has an acute on chronic problem in that left pelvic limb, given the atrophy. There's a left medial luxating patella that I think is predisposed to a cranial cruciate ligament rupture. There's a little ski slope off the left of the lateral aspect of the tibial plateau. Maybe you could talk about some OA. I don't know, man. That's like equine type OA. So that's what I got. I think he blew a cruise ship in that left limb, and he's going to be great. He's going to do fine. Any questions, concerns? Oh boy, here we go. Okay. I'm not going to give you a history on this one, and you can tell me the history. I'm going to give you 2 minutes, 3 views of the chest. Got a left lateral view, right lateral view, and a VD view. Okay. No history. Go for it. History is for suckers. Okay. Maybe what I should start doing with you guys too is no history. I mean, unless it's like a musculoskeletal, like the last one where you're going to spend 20 minutes scrutinizing it. But on a case like this, I feel like it's nice because, again, that's how I usually interpret radiographs, especially if I have a lot of time on my hands, where I'll pull up the case, blinded, form an opinion, look at the history, and try to refine my ability to pick up disease and clinical usefulness. Hopefully you guys have an opinion. Here we go. It's a young cat, okay? You've got the proximal humeral physes remain open. Those usually close down about 15 months. The caudal end plates are closed. Those usually close about a year, and they close down from cranial to caudal. But this physes, so he's maybe a little over a year and a half. I mean, he's getting close to 15 months, 16 months, something like that. I think the cardiac silhouette's normal. This is a little bit of fat. You can see it. It's right. It's a little bit of fat. Okay, this is fat. Okay, so he's got this rim of fat, and that helps you reconcile in your mind, why does the cardiac silhouette kind of look chunky on the VD view, but not the lateral view or the other lateral view? So cardiac silhouette's normal. The trachea is normal. The cranial mediastinum is normal. So it's not particularly wide. Then I look at the pleural space. I don't see any pleural fluid. You look for rounding here, and you look for loss of the liver diaphragm margin here. It is a well-fleshed cat. He's obese. As far as the technique, these thoracic limbs are pulled caudally, but he's a cat. He's probably not going to let you do it. I think they're pretty damn good. The VD view especially is incredibly good. So these nurses have done a fantastic job, or technicians. I would describe this as a moderate diffused bronchial pattern. I think there are some ill-defined sort of like nodular areas here, maybe there, I don't know, maybe here and over there. And so I would diagnose this as moderate diffused bronchial pattern with several multifocal ill-defined nodules. My guess is this is lower airway inflammation like feline asthma. Other causes, infectious / parasitic pneumonitis. So you could do mycoplasma. He's pretty young, so probably not heartworm. I mean, people throw out toxoplasmosis, but that's quite an aggressive, I feel like, diagnosis for a lung pattern like this, though that's possible. You could do a Leurostrongylus, so parasitic, Leurostrongylus, mycoplasma. The nodules, so you could have a couple of explanations for those. So you can get endobronchial mucin. So these bronchi, they impact with sort of this mucinous concretion. You could get little granuloma, small abscesses. Those are just sort of like the general things. I feel like small abscesses are not very common. I feel like the endobronchial mucin is pretty common, especially with chronicity. I feel like you could have some granulomas. Now that you see the little maybe granulomas or these little tiny nodular things, you could talk about fungus. This cat may be coming from the Southwest, United States, that is. Inhaled irritant is another one that you just kind of throw out. This is one of those where you just say these things and then you kind of throw it back at the requesting doc, and then they have to piece together other information that they have, such as travel history and an additional workup. The liver is floating. Yeah, Dr. Walsh is talking about a floating liver. This is falciform fat, extraperitoneal structure, very well-fleshed cat. I love a fat cat. Chest x-ray is great. So I'm going lower airway inflammation on this cat. And that's it. That's all I got. Not cardiac. Sometimes also, I think I was taught, and I've seen it, maybe not in this particular case, but if you have really thick airways, these donuts and these rings and lines and donuts that go to the lung periphery, sometimes if they overlap, if the lung pattern is really bad, you can get a bit of a nodular, almost like a subtle miliary pattern from just thick overlapping airways, as opposed to things jammed into the airways. Here we go. I'm going to tell you the history on this one. But I don't need to tell you the signalement. I can tell you the signalement after. But we've got 4 views of the chest, and the patient has a respiratory presentation, so he's having a little bit of trouble breathing, and it happened fairly acutely. 4 views, 2 minutes, have at it. So, all right, we got 4 views, right? A couple of laterals, VD, respiratory distress. So the signalement, I think you can gather, right? Brachycephalic. It's got the hemivertebra, the wedge vertebra, the anomalous vertebral bodies. You can also get this sense from the caudal fossa, just kind of a little bit flat, but you kind of get this impression that there's extra soft tissue right here. That's probably his soft palate. And I think that that's probably an issue. One of the things that I wanted to show you was that the dog's expiratory, right? So he's expiratory a little bit better. And for a bulldog, that's pretty good. But you'll notice that when you look at this view, that's a little more open compared to this view, where it's more just sort of ill-defined soft tissue, and his hyoid's a little bit caudally retracted, and he's expiratory. So he's probably having a hard time, or at least you've just timed it such that he can't get air. On this view, he's done a better job at breathing. On this view, telling you it's probably a little bit dynamic, whatever's going on. And so when you look at these caudal dorsal lung and you go, oh boy, he's got heart failure or non-cardiogenic edema or some sort of fluid, it's less supportive on that view. That means you should chill out. And then you look on this view and you got nothing. So even though it's a VD view and it's not the ideal one for evaluating the caudal dorsal lung, it's still fine in most cases, and in this case, it's totally normal. So that tells you that you're dealing with a not necessarily atelectasis. It is kind of atelectasis. You just don't have as much air. So it's an expiratory radiograph. There's less gas to offer differential attenuation with the regional pulmonary markings, the vascular markings, the bronchial markings. Okay, so the other thing is you got this nugget right on midline here. And this sort of margin, this sort of bulbous margin right here on the lateral view, I think if you hallucinate, it's probably something right here, but I wouldn't fault you. I'm not overly convinced that there's something right here, but you kind of hallucinate here. But even if you didn't have this, and even if you didn't have this, and you got this, this is a hiatal hernia, and my guess is it's sliding because you don't really see it as well. And so in this particular patient, I think you can make a case that he's got an upper airway problem, and then that can lead to a hiatal hernia, which is here. You can also, in this particular breed, get a congenital developmental cause for a sliding hiatal hernia. But I think the lungs are normal. The big thing to take away, the big thing that I feel like these clinicians want to know is why the hell is the dog why is he trying to die? And when this breed goes on the x-ray table, the big question is it going to be something in his chest or is it upper airway? And what you want to tell them is that the cardiac silhouette is fine. The pleural space is fine. I think the lungs are fine. He's got this, which is a sliding hiatal hernia, which can help support an upper airway etiology. It most likely is related. So he's trying to breathe against that collapsed oropharyngeal, laropharyngeal region. And so that negative pressure is just sliding that thing up. Okay. No pneumonia, no heart failure, no pulmonary edema, upper airway dog. Yeah. And then as far as collapsing trachea, so this breed tends to try to breathe through a straw anyway. And this is a little bit more narrowed relative to that. And if you wanted, you could drop you could get a ratio if you really wanted to break out a ruler, and you drop the ratio there, and then you go to the thoracic inlet, and then you plug that into your little calculator, and you'll get a ratio that'll tell you whether or not this is a pathologically narrowed trachea. And there's different cutoffs for brachycephalic and brachycephalic bulldogs and non-brachycephalic dogs. I think bulldogs can go all the way down to like 9% of thoracic inlet diameter relative to tracheal diameter. So there's a little bit of narrowing here. I don't know if it's enough to say that it's collapsed. There should be a normal bit of movement. But I didn't diagnose tracheal collapse in this dog. I said there's something going on up here, which is probably this breed, and that he's pulling the hernia, and he doesn't have all these pertinent negatives. And he just ate, which may be contributing to this little bulge right there. I don't know. Sure, I think, could the upper airway narrowing be related to? I think it could. It could also just be edematous because it's just smacking and he's trying to breathe and it just gets more and more inflamed and edematous, and then it's this cycle, and then he just gets worked up, and then it just gets worse, and it's not been incited by any particular hypersensitivity or a bee sting. I would not be surprised if this was just a bulldog trying to live. Once upon a time, somebody, asked me about, let's do this one. Okay, so there's 6 rads, but we're going to just focus on the abdomen. Okay, so the patient is lethargic and not eating, and they're worried that maybe he vomited. So this response from Angela is suggesting that she believes that it's not a surgical abdomen. So here's what I would do, okay? So we know that it's a cat, right? It's got long lumbar vertebrae. We know it's young because he's got these open physes. You can also see sort of this little physeal. Get the faint physeal little remnant, if you will, on the end plates here. But it's a young kitten, right? So caudal thorax is normal. The liver is normal. Here are the 2 kidneys. They're superimposed with one another. There's the urinary bladder. It's small and fluid opaque. Okay, and then I'll show you the splenic head right here, little triangle of love. The spleen kind of runs along here. It's not enlarged. The next thing that I look at is the colon, and this is well-formed feces, which to Dr. maybe Amelia or Angela, somebody pointed out, and I think it's good that this supports an acute onset. So maybe we've got a little bit of time. The next thing I look at is the stomach. So here's the stomach for those that don't see it. It's right up here. It goes right up here, right up there, right there. Okay. So the stomach, I would describe this as being mildly distended. I would say it's distended. It's mildly distended with a combination of fluid, gas, and small minerals. I don't see the minerals support like a dietary indiscretion. It could be litter, but it could be something else. And then the trickiest thing is always the small intestine. So we talk a lot of times about size, course, and content. So the size. Everybody looks like a little bit enlarged, either with some fluid and some gas, but mostly gas. The course, size, everyone looks like they're sort of similar size, right? Everybody's at the same party. They're all kind of a little bit big. There's some stippling of some gas right there. The course, there's gas bubbles, but I don't see plication. So really we're looking for plication, which when you use that term, you're going to imply linear form body versus corrugation, bacon strip. You're talking about enteritis. So for me, these look like they're uniform in size, a little bit too dilated, mostly with gas, some fluid. They lack plication. And we kind of talked about the content, gas or fluid. So I would just come right out and say, I don't think based on this study that the cat has an obstruction. And I think because you've got the formed feces and an acute history, you could maybe do 12 hours of supportive care. Fast it, though he's young, so just kind of monitor, although he's probably not going to be hypoglycemic. And then you could repeat rads. I think an abdominal sonogram would be another good idea as well. But if you fast him and repeat the rads, and the stomach, he hasn't vomited during the interval and the stomach is empty, the small intestine is reduced in size, I think you're well on your way to trying just continuing to do sort of conservative measures. So if the sort of impression of bunching bothers you, you could definitely do an abdominal ultrasound at this time. That volume of fluid is not really normal in a cat, and you've got the mineral, so there's some foreign material. It's not really normal. So I think you're totally justified for doing that. But to me, this looks like a gastroenteritis, and I'm not sure why. He's young, so you want to rule out infectious stuff, parasitic stuff, and then foreign material. So I think this is a hard one, I think, Steve, about the comma-shaped gas-filled loops plication. The thing that I don't like about plication in this particular cat is because you'll look at where the small intestine is in the abdomen, and it's kind of everywhere that it is allowed to go. So it's not bunched necessarily in one spot. In other words, some is kind of crept up in the cranial. There's some in the middle. There's some in the caudal. Okay, some in the cranial, some in the middle, and some in the caudal. So it's kind of doing this. And then when you flip the cat on its back, you've got some in the left gutter, some up here, you got some up there, and some up there. So you've got this sort of bubbly looking small intestine, and you're going, oh shit, is this plicated? Do I have a linear form body? I'm kind of worried. But then ask yourself, well, why are these loops kind of allowed to accommodate different parts of the abdomen? And so that's why I'm like, you know what, we need to probably chill out and not cut the cat. But I think that's why I like this case, because I think that I don't know how else to describe it. These bubbles are very round looking. There's a lot of round bubbles. And remember, linear form bodies in cats, you'll think this is funny, but they're usually easy to diagnose. Versus a dog, linear form bodies I think can be challenging. But this, to me, looks like the cat got into something. Piece of cake, right? You could try the compression, the spoon paddle, if you really wanted to piss off the nurses and the cat. Just gently press a spoon right on here, wooden spatula, and then take a rad, and you'll see it. They'll kind of splay out a little bit, and then you'll be able to see. That can sometimes help. For me, I think the thing is, if you're not sure, then do another test, right? I think if you're debating, you look at this and this cat, and you go, he's got formed feces. This just happened. All the small intestine, everybody looks like they're sort of the same size. So you've got a little bit of time. Okay, 3 views of the abdomen on this dog. He's got abdominal pain and he's vomiting. Okay, there's a right lateral radiograph, a left lateral radiograph, and a VD view. Okay. Oh, Steve is feeling it today. Yeah, man. Focal loss of serosal detail, cranial abdomen. It's brilliant, spot on. That's exactly what's going on. You use the anatomy, you use the appropriate Röntgen signs. I know where you're talking about. And now everybody that just read that or heard you say that, they start going, oh, he's got a pancreatitis, right? So that's what you want to do. So right here, it's nice to show you. This is wet hair. You see this? These little striations are wet hair, but this is not. That right there is a loss of serosal detail, okay, in the right cranial abdomen, and there is a loss of serosal detail. So he's a well-fleshed, he's a fairly large dog, which means there's a decent amount of fat in there, and so so you have to have a decent amount of either fluid or inflamed fat to overcome that ability to discern. So there is a loss of cranial and ventral abdominal serosal detail confirmed on the lateral views. Most dogs, especially a well-fleshed dog like this on a VD view, they always look like they got a loss of serosal detail, so you got to chill out. Okay, here's the left kidney. That's normal. The right kidney is hiding under here, but you can see it really well. There's the right kidney. There's the left kidney. Those look pretty good. Could they be a little skimpy? He's probably older. The liver is pointy. That's nice. Gastric axis is parallel. That's great. Urinary bladder is small. That's great. Is the spleen a little bulbous? I mean, it's probably fine. Maybe it's a little hyperplastic. You certainly shouldn't be saying anything else. Maybe he was acting up and they gave him a little bit of a sedative. So the colon, this is a great example. If I flip the dog on his back, you'll notice that the colon right here, this is probably cecum, L25 right of midline, and it pops off and it probably goes around like this, right? This is corrugation. Okay, this is corrugation. That last cat, it didn't look like this. It looked more like bubbly and it was kind of taking all these, it was taking more like rounded turns like this, but this is a corrugated. That colon is not happy, okay? So this loop could be the duodenum. Maybe the duodenum is probably a little bit of fluid. But again, so the stomach, small amount of amorphous soft tissue with admixed gas, that I think we should sort of shelf for later. So the way that I would diagnose the small intestine is, even though this is jumping out and you want to freak out about a sentinel loop and all that, it's not that big. Everybody, there's loops in the cranial, the mid, the caudal abdomen. It's a little bit bigger, but it's also mostly full of gas. So I think you should look at this and go, this is not an obstructed dog, because you've got this angry colon, you've got this loss of serosal detail, and you've got some of these loops that are fairly empty or mildly gas-filled. I don't see any foreign material. And so you've got some amorphous soft tissue in the stomach. So the way that I would diagnose this is, I would say there's a loss of cranial abdominal serosal detail. Priority should be given to like steatitis or effusion related to maybe pancreatitis. There could be other sinister stuff, like even though the liver looks fine, maybe you have a complicated gallbladder mucocele. You could potentially have like a PLE, although it seems to be more concentrated to the cranial abdomen, so a protein-losing enteropathy. And then you can just throw out things like a sepsis or hemorrhage or neoplasia and all the other shit that's not helpful. But you could say, I'm worried that the dog has pancreatitis in this particular case, because you have the loss of serosal detail, because you have the pain, because you have the vomiting. You could absolutely, you probably should do an abdominal ultrasound. This, you want to make sure you're not dealing with foreign material. So things you could do is you could ultrasound it, see if it's got these strong shadowing characteristics to it. Although recently ingested food can also have strong shadowing characteristics. I really, really, really love fasted repeat rads for seeing if the stomach will kind of empty out. Now, caveat, if you have pancreatitis, you may get a delay in gastric emptying, and then you retake the rads and you go, oh my God, it's still there. But this is a non-obstructed dog. He's got enterocolitis, more than likely. He's got a loss of serosal detail, and he needs an ultrasound. Okay, and now we have an ultrasound, but I'm going to do something really quickly to make sure I don't give away his name. All right, so we got a sonogram right here, okay? So let's see here. Here's your liver, little nodule, little scary looking mass-like thing, but that, I don't know. You're not going to see that on the rad. Probably didn't see that on the rad. You could harpoon that, drive a biopsy or do cytology, a needle. Gall bag right here, thin wall, that's normal. So not a mucocele. So you've got this sort of couple of liver nodules, sort of this hypoechoic mass. All the word mass is very scary. But it could be nodular hyperplasia, it could be hepatoma, it could be carcinoma. Doesn't really look like that really, really, really hypoechoic multicentric neoplasia like histiocytic or lymphoma. The spleen, a little bit of fluid, okay, peritoneal fluid, a little triangle of love right there. The spleen doesn't look that bad. That's a myelolipoma. Don't worry about that. This person's calling this the left limb of the pancreas. I kind of agree. Could be, because there's the spleen up there, and this would be in the area. This is all fat, and the fat looks not happy. If that truly is the pancreas, it's way too conspicuous, especially the left limb, and this is angry or hyperechoic fat. Left kidney, a little bit of pelvic dilation. You want to talk about pelvic dilation, that could be from fluid therapy. It could be from pyelonephritis. This kidney looks pretty good, so things like renal insufficiency, which can also cause mild dilations of the renal pelvis, is probably not going to apply here. This isn't big enough or severe enough that I get all bothered about a ureteral obstruction. So maybe the dog's PUPD, maybe he's been getting fluids prior to the ultrasound. Here's his adrenal gland, that's normal. That's a chunky pelvis on that left kidney. Here's more fluid. That's a medial iliac lymph node, I guess. Probably is, because we've got some bifurcation right here. What else? Urinary bladder. This sonographer did a great job. They measured on the near field wall, not the far field. So this has got, looks like moderately distended with anechoic urine. Prostate looks fine. Peritoneal fluid. So this fat, not happy. This fat, more happy. Steatitic, fluid. Plus, with the fluid, you can also have reduced attenuation. We'll call it through transmission artifacts. So stuff deep to fluid can actually look more hyperechoic. But I think that that's real. Here's the right kidney, a little bit of pelvic dilation. What do you bet that the dog was hospitalized, put on fluids, and then scanned in the morning? Oh boy, look at this near field. So that's the right limb of the pancreas. Right kidney near field. You're going to get the right limb of the pancreas. It's really pissed. Here's your bacon strip, right? There's corrugation. Look at this thing. Let's get another one. We got another one? No. Okay, so there's a little bit of undulation to this thing. So that's the corrugation. So he's got some duodenitis. This is inflamed fat. Wall layer's fine. Pancreas not fine. There's your bacon strip, everybody. So that is enteritis. Okay. Done. 3 views. Dog is coughing. Here we go. Coughing dog. You got 2 minutes. I cannot wait to hear what you guys say on this one. Where's my banner? Check this thing out. Oh yeah. Size, shape, number, location, margin, opacity. You can use some of those. The size. You're not going to be able to. The shape. That could be important. The number, the location, the opacity. Remember, I like to start with the location first and keep things simple, right? The cat is fat, period. All right, so if you guys have an opinion, I got an opinion. This radiograph is it's pretty good radiograph. Nice exposure, decent positioning. Thoracic limbs are pulled forward. It's not that rotated, not too much of the abdomen. I like it. The VD view, not so bad. You've got the spinous processes right here. Dog's a little tipped off. It's a little straighter back here. But it's pretty good. This view kind of sucks, but it's not bad. You know, his ribs, they're tipped up, but he's not happy, right? And we've got way too much of the neck. Okay, so what else we got? We got right lumbarization. So the way I would diagnose this is you could say in the hilar region of the right cranial lung lobe, there is a focal increase in opacity, a focal increase in soft tissue opacity. The next thing that I would want to talk about, right? So, okay, so you see this opacity. You're going to describe it as an alveolar opacity, right? Because it kind of effaces blood vessels. So you've got an alveolar opacity in the right cranial lung lobe. Just non-specifically, your 3 options are atelectasis, pneumonia or something like that, blood, pus or fluid, or a mass. So atelectasis, in my experience, tends to start more ventrally and it kind of works its way up. And it tends to have classically a bit of a triangular appearance. Okay, so that's what's important to describe this as more hilar. It's up toward that hilum. Hilar. The other thing that I find interesting about this, not helpful in this view, but this view. Now, could this be because he's rotated? Maybe, but I think it warrants a discussion. This border almost looks round. You know, so on that Röntgen sign, you're talking about margin or shape. I mean, when have you described a shape of pneumonia? Pneumonia doesn't really have a shape. It's just a bunch of angry lung and pus. This thing has a little bit of a margin. Maybe I'm getting tricked because he's rotated, but I'm worried there's a mass in this right cranial lung lobe. Based on this view, it could be peripheral enough that you could harpoon it, get an ultrasound up there and stick a needle in it. I was taught if it swells, you should stick it. So a couple of things you could do. To me, this is not straight up pneumonia. It could be, but I don't think that should be prioritized. I think that you should be worried about a mass, and I think things like primary carcinoma, you could potentially talk about histiocytic sarcoma, you could talk about a granuloma, whether that's from an eosinophil or mycotic disease. This is solitary, and so METs are possible, maybe less likely because those tend to be more numerous. And so you could make up some shit about an abscess or something called a bronchocele, which is just a almost like a cystic structure from pathologically distended bronchi. But I think I would be worried that this is a primary lung tumor. I would recommend, if you could, do a CT. Most people can't. I can't do a CT. So the next thing that you could do is you could throw some antibiotics at it, and then you could have it come back in 14 days, and then it looks the same or it looks worse. You could try to ultrasound over that area and stick a needle in it. What else? What else can we learn from this? This is peripheral enough on the properly positioned VD view that you shouldn't be getting that excited about a tracheobronchial lymph node. On the right lateral view, let's do it. On the right lateral view, there's a perihilar hazy increase in soft tissue opacity. There's a perihilar hazy. Increase on that. Yeah. Yeah. So a couple of things. So this is kind of getting into the area of the right middle lung lobe on the VD view. I agree. However, the right cranial lung lobe, I think, is a little bit underinflated. So that left one comes around, right? Here gives you the old little reach around there. But the right cranial, it also tends to come around over here, right? You get that mediastinal reflection. It comes up. So I think the left cranial lung was a little bit underinflated, which is probably pulling this back. But we know that this is not right middle, because the right middle, it makes, this is where the right middle lives. Not right there. That's where it lives, right? Here's the bronchus. Trachea, boom, right middle lung lobe. Bronchus comes right down here. So this is the confines of the right middle lung lobe. So this thing is more dorsal, right? If this thing was right here, you still wouldn't be talking about right middle. So this is not right middle. It's going to be right cranial, and it's a hilar position. So that's why I don't think this is atelectasis. That's why I feel like this could be pneumonia, but I don't like it's got a little bulgy margin. So I don't know what this is, so it could be wrong, and he's going to come back with his resolved pneumonia in 10 days. But I think they need to stick a needle in this, or at least get more imaging. If you do a CT, it's probably going to answer the question of, do you see a contrast enhancing mass? All right, here we go. Acute collapse, severe tachypnea. It's like a middle-aged dog. Bronchoscopy. On the other dog, you could do a bronchoscope. Yeah, if you can get into that right cranial lobar bronchus in a smaller dog. I'm not sure who can do that, if you can do that. I think on that VD view, it looked like it was up against the wall, so you're not going to get any lung in between. And so I think you could probably ultrasound it. 3 views. Dog is collapsed, severely tachypnic, and the new intern on the ER hears a heart murmur. The intern has just come back in and said they believe that the murmur is a grade 4 or 5. All right. Air bronchograms. Jane, you are right. There are air bronchograms up in this stuff. Perihilar to caudodorsal alveolar pattern. Boom. Boom. Yep. Air bronchogram. So Jane's saying air bronchogram. So she's saying she sees an alveolar pattern. I agree. Steve's saying perihilar to caudodorsal alveolar pattern. I agree. Okay. So if those of you are new and you're like, what in the hell's going on? You could start with the lungs are abnormal, period. Okay. That's the first thing that you can say, right? They're abnormal, and you feel very strongly that they're abnormal. Then the next thing that I would do, Angela says increased caudodorsal contrast, increased contrast in caudodorsal thorax, expiratory, right? Definitely expiratory, a little bit expiratory, but it's pretty bad. And then when you flip the dog on its back, you're like, nah, I still see it. Remember that bulldog with that midline hiatal hernia, and it looked caudodorsal, and you flip it over, and you're like, wow, it's just like normal, right? This dog, not normal. So now we're like, game on. There's something up there. But what I would do is I would say, look, these lungs are not normal. First, he's rotated, not his fault. He's trying to die. The lungs are not normal, and there's an abnormal lung pattern here. The whole lung looks pretty abnormal, right? I think one of the cool things about this case is that the lung up here is not normal, and the lung up here, you can see that, right? That's almost, it looks bronchial, but I actually wonder if the interstitium is full of fluid, and then it's surrounding the bronchi to give you this sort of like peribronchial, not a cuffing, but more interstitial as opposed to thick bronchi. But that's an abnormal pattern. But if you had to draw a line through the dog's cardiac silhouette obliquely, you have to ask yourself, where is he worse, caudal and dorsal or cranial and ventral, even though it's everywhere. And I think we've all talked that it's worse caudal and dorsal. And that's important because I love distribution, right? If you go, it's caudodorsal, you first, the next way you go down your little algorithm tree is you go cardiogenic or non-cardiogenic pulmonary edema. Now, is the cardiac silhouette abnormal in this dog? I actually think the cardiac silhouette is normal. This trachea does not look abnormally displaced. This doesn't look abnormally wide, right? If you had right ventricle or if you had right-sided cardiomegaly, this whole area tends to get filled in with tissue. Yes, there's lung obscuring this area, but I don't get the impression that there's a bulge in his left auricle, 2 to 3 o'clock left auricular bulge. If you guys hallucinate with me, I'll show you where the trachea is. If you come down here, it's right here. Comes down, comes down, comes down. This is the right lateral margin. Comes down, look, and then it stops here. Right cranial lobar bronchus, right caudal lobar bronchus, left caudal lobar bronchus, and then the cranial bronchus right here, the little left cranial subsegment and left caudal. So there's your carina. So this is your cowboy, cowgirl, whatever sign, right? And it doesn't look overly opaque there, right? This is pulmonary veins kind of coming in here. I don't get this impression that this thing goes up like this, right? If you're like, holy hell, I can't see anything up here because it's just lung and disease, you know, I'm not going to fault you for that. This is rotated. So yeah, I don't know. You got to be careful. Okay. But they've told you that the dog has a 4-5. Yes, it's an intern, but maybe it's 4-5, and you believe them. To me, this reeks of a ruptured chordae tendonae. So dogs that maybe have a 1 or a 2 murmur and they're doing fine, and then that thing blows and it just goes, and they have just fulminant, severe caudodorsal lung pattern. And then you look at the rads and you go, well, the heart's not that big. The cardiac silhouette's not that big. What's going on? And that's one of these cases where you go, you just got to give the dog Lasix. So this cranial lobar vein is kind of chunky, and it's kind of chunky, right? This is the left lateral view. So the trachea comes down. This is the right cranial lobar bronchus right here. That's the right cranial lobar vein, right cranial lobar artery, and the vein. And that vein is kind of chunky. I usually don't pay a lot of attention to pulmonary blood vessels in heart failure cases because I feel like in a lot of cases they're not that big, but in this particular case, I think they're chunky. So for me, I think what makes me go heart, I mean, I didn't try to make this cardiac silhouette big. I just said, look, the cardiac silhouette's fine. He's got a severe, predominantly caudodorsal lung pattern, and you're telling me he's got a raging murmur. My suspicion is he's blown a cord, and this is left-sided congestive heart failure, and he needs Lasix. Did I misspeak? Yeah, vein is bigger than the artery. The vein is bigger than the artery. So this is one of those where you got to be careful that you don't say, well, the cardiac silhouette's not that, it's not abnormal at all, so it can't be heart failure, and so it's got to be non-cardiogenic edema. I mean, the number of times in a week that I say cardiogenic pulmonary edema relative to non-cardiogenic, I mean, I feel like I hardly ever say non-cardiogenic pulmonary edema. It's always the bloody heart. So just play the probability. Give the dog Lasix, get him an echo. What about non-cardiogenic? Yeah, I don't think it's going to be non-cardiogenic. I just don't think when you've got a murmur 4-5, you know, and then you've got a fulminant caudodorsal lung pattern, to me, it's a blown cord until otherwise. And as Dr. Walsh, I think, astutely pointed out, it hasn't had time to stretch. And the same goes with pericardial effusion. We talked about that once upon a time, where we always think, well, the dog's got to have a globoid cardiac silhouette in order to have pericardial effusion, but that's not the case because it depends on the volume and the chronicity. So those globoid cardiac silhouettes tend to have a decent amount that's acquired over time. So if you have a dog that's got a little bit of a left-sided cardiomegaly and he just collapses and tries to die, maybe flash him and see if he's got pericardial effusion. Okay, 7 cases. This is going to go up on YouTube for the 2 followers. It's going to be great. I'm going to go home and eat dinner and go to bed and do this again tomorrow. I'll see you next Monday. Let me know if you have any questions. Feedback is helpful because Dr. Walsh gave some feedback and I felt like we just dialed in on what she wanted. I'm not doing this. I'm doing it for you guys. I enjoy it, but I want you to get the most out of it. So have a great night, and I will talk to you guys soon.